Professor Bashar. I present a case which underwent surgery, retinal surgery. It is a case of advanced diabetic and eye disease. Here there is OCT of preoperative procedure of the patient that is hypovascular proliferation addition overlying the macula, and during surgery giant tear was developed and managed. First, that is poor vitrectomy was done, and then transuranic acetonide was given to stain the rest of the vitreous. Try to trim, that is the hypovascular membrane from the periphery. Then I used forceps to release the membrane with minimum cooling, so that there is no development of iatrogenic retinal tear. And then again the membrane was trimmed finally by use of forceps. It was removed from the upper macular area. Then again fold and try to remove the membrane, then again trimmed, as because with cooling there may be a chance of develop retinal tear. So by means of cutter with minimum traction force, the membrane was tried to remove, and to release the traction, going into the cleavage between the membrane and retina. The membrane was cut to release the traction force. Again by use of micro forces from the another end, let us try to remove it. As it is the membrane in the macular area, so I don't pull it too much, because tear formation in this area will be a disaster for the patient vision in the later period. So I try to release the traction and start the membrane. Again I feel this is enough that if I pull it too much there will be chance of retinal tear, so I leave it as I think the traction force is relieved. Then I feed the fluid air access to do the ILM field. During the giving of brilliant blue, it has to give gentle drop by drop, because if forcefully push the brilliant blue, it may cause the retinal tear. Or try to do the ILM peel. Then I noticed that this giant tear was developed on the nasal side, and it was a alarming situation, particularly in this patient. I think the patient has undergone the PRP laser before this, and in case of diabetic patient there is also a, that is, retina is vulnerable due to ischemia. So during fluid their access and again the fluid there, this force may develop this tear. Fluid flow, that is infusion fluid may cause this tear, that is it cause a giant tear, because infusion fluid force cause tear in the opposite side. That is, if the infusion fluid is on the temporal side, it will develop on the nasal side, and after giving the PFCL and cauterization, after cauterization of the blood vessels, then I trim the some part of the retina to make it well blood, as because there is this leaf, both anterior and posterior leaf will be trimmed. If you do not trim it, it will cause, that is, further detachment, and also that there is anterior leaf also to be trimmed, because if anterior leaf is not trimmed, that will cause, that is, pulling of the ciliary body forward and cause, that is, ocular ischemia, and this may develop phthisis bulb. The laser was given, that is 2 or 3 rows, Then again heads was done. I like to do the fluid air access, not direct silicone and PFCL access. And during this access, there is fluid needle or there is active suction always in the tear margin. Always keep it to dry. That is just above the fluid. It's always keep it dry. Otherwise, it may slip. The fluid may slip. So I always keep my tip, the fluid needle tip, always in the giant tear margin to make it constant dry. And when the fluid is going down the tear margin, and this tear margin is after filling with air, then I can go in the centrally to remove the rest of the fluid and PFCL also. And then you see that I always try to keep it dry so that the retina cannot slip. Then after when the fluid is going down the tear margin, then I aspirate the fluid as well as the PFCL, PFO. And this procedure I always try to avoid the PFCL silicone oil access. That is then silicone oil, air silicone oil access was done, and I just palpate the flow whether the pressure is adequate or raised. Then I close. That is the 23 case surgery, so I think that it is better to close the entry point. There is 3 port. I close the port. And after surgery, this is the situation of the macula. You see, there is no more traction on the macula area. And before surgery, there is, you see that 2 mass fibrous membrane over the macula. Thanks for patience of seeing this video.